Good evening. My name is Mohsen Malani, and I'm the Executive Director of the Center for Strategic and Diplomatic Studies. On behalf of our center and USF World, I welcome all of you to this virtual conversation about the corona crisis. This is the first virtual conversation our center has ever organized, and it won't be the last. Rest assured that we will not allow the coronavirus to decrease our activities as we take our commitment very seriously to educate and inform our students and our loyal supporters. In fact, we have been working diligently on the past few weeks on organizing a number of virtual events within the next few months. The distinguished members of our advisory board have urged me to develop new techniques and new plans to go national and international. And our center plans to do exactly that. Now we have that chance. As a matter of fact, I know a number of people who have joined us have come from other states as well as other countries. If you are not in our list served, please, I urge you to go to the question and answer icon on the right-hand side of your screen and send us your name as well as your email address so that we can include you on our listserv. The format of tonight's program is no different than the format I have used previously. After my conversation with our distinguished guest, you will have a chance to send your questions. In fact, throughout the program, you can send your questions. Please go to that question and answer icon on the right-hand side of your screen. It is now my great pleasure to introduce Dr. Kiki Krusen, who will introduce our distinguished guest tonight. Dr. Krusen, as many of you know, has replaced Dr. Roger Brindley, who is familiar to many of you. He is no longer with USF and has accepted a new position at another university. He was a great supporter of our center. We miss him and we wish him the best of luck in his new endeavor. We are truly lucky to have Dr. Krusen to lead USF World. Dr. Krusen leads USF's global engagement, including study abroad programming, international student and scholar services, into pathway programs, and management of international partnerships, the Global Discovery Hub, initiatives that support research and scholarly activities, Peace Corps programming, international alumni outreach, as well as global development activities. She does all of that. She is the author of numerous prestigious publications, including Globalizing University Research, which was published 3 years ago, actually in 2017. She received the inaugural Big Ideas Award, including the funding from the Society of Research Administrators International for the creation of a peer resource web-based global research toolkit. Dr. Krusen is an alumni of India Fulbright Program for Senior International Education Administrators. She has led student groups to Panama, India, Peru, and twice received Outstanding Teaching Award from the university. A faculty member in the School of Interdisciplinary Global Studies, Dr. Krusen maintains an active interdisciplinary research portfolio. She is an advisor and mentor to graduate as well as undergraduate students. I can testify as her colleague that she is truly a prolific researcher and a fantastic teacher. And she has served in leadership roles in a number of professional organizations. It is truly a great honor for me to introduce Dr. Kiki Krusen.
Thank you, Mohsen, for that very, very generous introduction. Mohsen hired me 20 years ago as a junior faculty member, so he and I have a long history together, and we've come full circle, and now I'm able to help support the Center for Strategic and Diplomatic Studies as the interim VP for USF World. So it is truly a pleasure that I welcome you to the first virtual conversation with Dr. Malani. And before I introduce our distinguished guest, who is a real gem at USF, I'd like to take a few moments and share with you some points about the Center for Strategic and Diplomatic Studies. It was established 7 years ago as part of USF World. And during that time, the center has organized 12 major conferences about important international events. In addition, Mohsen has conducted over 30 conversations with prominent figures such as Thomas Pickering, the former ambassador to Russia, Mike Morell, the former acting CIA director, and David Ignatius, columnist for the Washington Post. Altogether, the center has brought to our campus over 120 prominent speakers and diplomats, including 13 former ambassadors and 2 Pulitzer Prize winners. From its inception, the Center for Strategic and Diplomatic Studies has offered programs that address emerging national security threats to our country, and tonight's program is no exception. As of today, more than 71,000 Americans have lost their lives because of the coronavirus, and over 1.2 million of us, fellow Americans, have been infected by this deadly virus. I cannot think of anyone more qualified to discuss the coronavirus crisis than our own Dr. John Sinnott. Dr. Sinnott is a physician, scientist, and chairman of the Internal Medicine Department at the University of South Florida's Morsani College of Medicine. He is the director of the Florida Infectious Disease Institute, which he started at the University of Florida, at the University of South Florida. Please excuse me, I'm surrounded by green, which he started at the University of South Florida back when he was named director in 1992. This institute helped spearhead a biodefense education program and built a nationally recognized infectious disease fellowship. In 2005, he was appropriated senior advisor to Florida Governor Jeb Bush for biodefense matters, and in 2008 served on Governor Charlie Crist's transition team advising on healthcare. In 2013, Dr. Sinnott assumed his position of chairman of the Department of Internal Medicine at Morsani College of Medicine, and in 2016, he was instrumental in arranging the Sister Cities Agreement between Tampa and Lanzhou in the People's Republic of China. And at that time, Mayor Buckhorn and the Sister Cities representative from Tampa traveled with Dr. Sinnott to sign the agreement. Excuse my inability to be an articulate host this evening. It is genuinely a pleasure to introduce Dr. John Sinnott for this conversation and to welcome you to the first virtual CSDS event.
Thank you very much, Dr. Cruzen, for your kind introduction. Dr. John Sinnott, on behalf of our center, USF World, and our university, and our community, and our state, and our country, I welcome you to this event. I know you're a busy man, and you have been kind enough to put aside a couple of hours of your busy time to deal with this serious crisis. So please accept my gratitude and appreciation for accepting my invitation to join us this evening.
I'm honored, Dr. Malani. Thank you.
Dr. John Sinnott, both of us are teachers. And so what I would like to do is to start with a little bit of history. As I was preparing the questions for this evening's program, I thought of this fantastic short quote by Cicero, the great Roman statesman, who said, and I'm reading exactly the translation of what he said, many moons ago. He said, to be ignorant of what happened before you were born is to remain always a child. For what is the worth of human life unless it is woven into the life of our ancestor by the records of history? So if you don't mind, I'm going to start with a little bit of history. And I want to go back to the Spanish flu of 1917 and 18. And my question to you, please educate us a little bit about that event. And more importantly, what do you think we learned from it?
The Spanish influenza was clearly one of the defining pandemics of human history. Previous pandemics had occurred in a less connected world and didn't spread quite as rapidly. In Fort Riley, Kansas, in 1917 in the spring, there was an outbreak of influenza. It was obviously contagious, and for unclear reasons, it faded away. It started to come back in September and October. World War I is going on. They're training all the farm boys from Kansas and Iowa in very crowded conditions, and then shipped them on a train to Boston, where it broke out in Camp Devon. In Camp Devon, the first day there were 3 patients. The next day there were 300. The next day there were 3,000. It was astronomical spread, but it was kept a military secret because it was felt it was limited to the US. They put people on troop ships, crowded troop ships, and shipped them to Europe. But this must have been an incredibly gruesome time because people were dying on the cruise ships, and they had so many die that they gave up official burials at sea. They would just take the name and dump the body off the boat. So that delivered the virus to Europe, where it readily crossed all the lines in all the countries. And since Spain was neutral, Spain pointed out that, by the way, a whole bunch of people are dying of this respiratory disease. Anyone notice? So it was immediately deemed the Spanish flu, although it wasn't. Over the next year, and it's impossible to estimate, but in his book, The Great Flu, The Great Influenza, it's estimated that 50 to 100 million people died during that pandemic. It went away, and you had used a quote from Cicero. I'm not sure who said this, but they said whoever can't remember history is condemned to repeat it. And I don't think we remembered what we learned here. We learned many facts that it was catastrophic to our economy. It was catastrophic to human beings. This was an incredibly overwhelming event, where in some of the slums, ambulances wouldn't go and people would just be thrown out into the street to decay. It was an unbelievably gruesome event. Now, what did we learn from that? We learned a bunch of things. Number one, we learned that medical systems have to have a surge capacity. In other words, whether it's an epidemic, whether it's a hurricane, whether it's a mass shooting at a nightclub, we have to have enough extra people, and we have to have enough extra supplies to deal with this. Because of this economic concept of just-in-time ordering, we found out that global supply chains can become dysfunctional overnight. So we have people delivering care without the right equipment. The second thing we noticed is that central leadership was needed. The United States is huge. You can't have one set of rules in Lakeland and another set in Tampa. And I thought the best example I could find of that was actually Minneapolis, St. Paul. And I've been to both of them and I couldn't tell them apart. But St. Paul had a health director that believed in isolation and social distancing and had learned about this idea of social distancing from a doctor named Tom Tuttle in Oregon. He found if you kept people further apart and if you used the mask, this dreaded influenza didn't spread. Minneapolis didn't see it the same way. They kept schools in session, left movie theaters open, and sports events. In October 16th, 1918, Minneapolis had 500 deaths, St. Paul had 10. So there's obviously a clear lesson there. They also found that you had to have community buy-in. People have to have clear information. And I'm afraid that because of cuts at the CDC, they haven't given a clear message. Remember at first, don't wear a mask, now do wear a mask. Don't wear a cloth mask, now do wear a cloth mask. People get confused. There should be a clear message of directions, like a handbook you open. Respiratory disease A, B, and C. Because there wasn't good community buy-in, just like we see today, there are demonstrations against it. There were riots against it. In Boston, a man not wearing a mask approached a policeman and was shot, which I would call strong law enforcement about masks. The buy-in from the school board in Minneapolis was not there. 3/4 of that school board was dead before the epidemic was over. St. Paul immediately closed all the schools, had much lower mortality. They had a variety of unexpected events occur to totally confuse the situation. The telephone operators went on strike. So people couldn't communicate by telephone well during this terrible epidemic. The second thing was the police stopped showing up. So they started having crime in the streets. Finally, both locations ran out of personal protective equipment. So the doctors and nurses, much like happening in New York, California, and Oregon now, are running out of personal protective equipment. So we're asking our caregivers to give care for very contagious patients. So like I said, much of what we learned in 1918, we've managed to forget by 2020.
Doctor, let me fast forward, if you do not mind, fast forward to what is happening today. Mr. Bill Gates has recently argued that the Western world, especially the United States, was unprepared to deal with the threat of any kind of epidemic, any kind of viruses. And his argument is essentially that we did not spend enough money, we did not invest enough in infrastructure, in other kind of things we needed to have. Now, in retrospect, when you look at what we have done in this country since January until today, would you please tell us, what do you think we did right? And what do you think they really missed? If you'd be kind enough to just focus on one or two, that would be very nice.
Okay, so what did we do right is we finally got the idea of shutdown of a city, and we got the idea of wearing masks. I don't think we're keeping to that, and that troubles me deeply. This virus is in no means gone. What we did wrong dates back about 2.5 to 3 years. In 2016, very clearly, coronavirus was identified as the second most greatest threat for a pandemic compared to influenza. It's very clearly conveyed to the incoming administration. Things that have been put into place, pandemic preparedness, that office was closed and very experienced people dismissed. The national security position for health was abolished. The budget for the Centers for Disease Control was cut in 2016 from $13.5 billion to $5.5 billion. So we were woefully unprepared at every level.
I'm pretty sure many of our listeners would like to know some of the basics about what they can do to protect themselves. So would you be kind enough to offer your advice on some of the basic but essential things we all need to do to protect ourselves from this deadly virus?
The number one thing that's simple to do is if you don't have kidney or liver disease, you should be taking 4,000 units of vitamin D a day orally. It clearly offers protection against viral infections. We don't know how, but every study done and the knowledge of infectious diseases, I can't cure infections if they're low on vitamin D. What is the mechanism? We don't know. Do I take 4,000 units a day? Religiously. 2 small capsules. Secondly, no one should be near other people outside their family without a mask. I cannot stress this enough. I was at a food store Saturday night. I'm a doctor. The woman in front of me obviously had COVID. She was sweating profusely, coughing, and had no mask on, which is a tremendous disservice because masks not only protect you, they also protect other people from your droplets that can travel 6 feet when you cough. And she's standing in line coughing all over the place. I just left the store. You should be washing your hands every hour, whether you want to or not, because you don't know what you're touching. I also encourage people to avoid elevators. They're crowded and they're pneumatic with dramatic changes in air pressure and are an ideal place to pick up a stray virus. When I purchase food at the grocery store, you often notice people will take something off a shelf, look at it, and put it back. Well, that virus can live 3 to 4 days on that can. So what I do is I will spray that off with a solution of alcohol, or sometimes alcohol and Windex. Just let it dry, and then it's non-toxic, and you don't have to worry about it. Outside, when you're around someone else, I want you to think of them smoking a cigarette, and where would that smoke go? And envision that smoke as coronaviruses, because that's exactly the way it travels. It's clearly spread by speaking, and it's clearly airborne. It's not limited to just coughing. As far as medications, people should not take Motrin, ibuprofen, Aleve, or any of these non-steroidal group of compounds. These agents cause a backup in the immune system with extra precursors for inflammation. So when you're sick, all of a sudden they're released. So people should just be taking Tylenol for their aching joints or headaches, not ibuprofen, Motrin, Aleve, or other substances. Finally, people should follow public health recommendations and get their influenza vaccine. In the fall, the influenza vaccine, and certainly the pneumococcal vaccine.
Thank you, Dr. Sinnott. My next question is related to the previous question, and that is, in your judgment, when do you think we can have a vaccine against this deadly virus? Is that within the next few months, few years, or would be almost impossible to predict?
Well, science, like the virus, is unpredictable. We could have a breakthrough with a new type of virus, a new type of vaccine. The idea of a vaccine that produces antibodies actually may not work. Because if you think of people that have, say, HIV, they have plenty of antibodies, but they're not protected. So we really don't know if antibodies are protective. With that in mind, a number of pharmaceutical companies are looking at, say, a once a day or once a week pill, almost like malaria prophylaxis, that would interfere with the RNA polymerase. And that, I think, is closer than a vaccine.
Excellent. Dr. Sinnott, you have been a great supporter of our center. You have attended many of our events, and you're quite familiar with the way I conduct these conversations. I start talking about basic and easy things, and then as we reach the end of the program, I start asking tough questions. So my next two questions are both tough and sensitive. The first one has to do with the origin of this virus. As you know, some people have argued that COVID-19 is a man-made virus manufactured in one of the laboratories in Wuhan, China. Some other people have developed this conspiratorial theory that, well, it really was not a man-made virus, it was a natural virus, but came out of the same lab by mistake. Well, the ramifications of the theories going to be truly incredible. In your judgment, specifically, is there any merit to this claim that this is A, man-made virus, and B, it was deliberately or by mistake came out of a laboratory in China, or it would be too early for us to render a definitive judgment about it?
Let me preface my statements by telling you I have visited that laboratory. The laboratory is not located in the city. The laboratory is about 50 miles south of the city. The confusion of the province, the city, and the institute frustrate me no end. Is it a biologic weapon? Common sense tells you that you would never use a coronavirus that way. These viruses mutate. It's already mutated into 3 different strains. RNA is not genetic material. DNA is. RNA mutates. So as a weapon, what you put in one side, you don't know what you're going to get out the other side. So that doesn't appeal to anyone's intellect. Just to make sure, the National Academy of Sciences and the Battelle Laboratory, as well as NIH, closely examined the RNA sequences involved. To manipulate that type of virus, you'd use a process known as CRISPR, and there you have to have repeated sequences, sort of as spacers, as markers, and there's no evidence of that at all. So the intelligence agencies think that that's nonsense. The scientists think it's nonsense. Having been to the laboratory myself, you can obviously subvert things for use, but they've been trying for 25 years to make a vaccine for coronavirus and have not succeeded, which makes you think it's going to be difficult. Could it have escaped from that lab? That's remotely possible. But the idea that the first 14 patients all came from the same wet market and the same store, and one person from the store next to it, suggested that, like HIV, like SARS, like MERS, like Nipah virus, it was an animal virus that mutated on its own and began infecting humans.
So it seems to me then that you essentially reject these conspiratorial theories, at least from what we know.
It's not just me, it's science in general, the intelligence community, and if you just sat there and looked at the 2 genomes together, you'd say this was not manipulated. This was just natural evolution.
The enemies of the United States, and there are many, have been watching this problem with coronavirus. And I have no doubt that they are thinking about use of viruses or other viruses to attack the homeland. That is a bioterrorist attack. I know you have done extensive research about this. As a matter of fact, you gave a fantastic presentation in one of our conferences last year about bioterrorism. And I'd like to end our conversation with something that is probably more depressing than the COVID virus, and that is, what can be learned from the way we have dealt this virus to prepare us for the possibility of a bioterrorist attack by the bad guys, by the terrorists? Are we really prepared to deal with this? Or are we going to, after being attacked, if that happens, and I hope it never does, are we going to go back and say, well, we weren't prepared? Are we really prepared to deal with such an eventuality?
We are not prepared now. It greatly troubles me that this weakness has been exposed so obviously to the rest of the world. There are people out there that don't like the concept of democracy, don't like the concept of freedom of speech. They're enemies of our country, and we have just shown them we can't deal with a natural event, let alone the great treachery a biologic weapon that would be designed to be hard to detect and very hard to defeat.
Thank you. Let me now see if we have any questions from the audience. This is new for me too, so I'm going to the question section. The first question is, what can we do? When do you think Tampa or state of Florida would be ready to go back to the normal times? Is that within the next few weeks, few months? What is your assessment?
Perhaps Mohsen would draw a comparison to 9/11. There was a time before 9/11 and a time after 9/11. They weren't the same. We will never return to normal after this. There's going to be a catastrophic depression. People are going to be full of fear about getting infected. It's going to take longer than people think to get this under control. I think that if we do everything right, we could probably stop wearing masks in 2022 and start returning to international travel at that time.
2022.
Right now in Tampa, the number of cases are doubling every 7 weeks.
That is not very encouraging. And what about another question is, when do you think, I'm not very sure who this guy is, he doesn't want to really identify himself or herself, when can I go to our local restaurants and to the local bars in Tampa?
No one quite knows. I certainly would not do it now. I would see what happens with this, what I would call a soft opening. It's very hard on me. I love to eat out. It's a social event. But for the moment, I'm staying at home. I'm keeping my wife home. And the vast majority of physicians, when you talk to them, are staying home as well. If I had any underlying disease at all, I would not remotely think of going to a restaurant or a bar where other people were. You might go to the beach if you're going to be around someone else, wear a mask. But, you know, social places, I feel, should be avoided for the time being.
I have heard, this is one of the questions, I have heard that the BCG vaccine may confirm some protection against COVID-19. What do you think? Apparently, he or she says that they have used that in Taiwan and Singapore and Japan and Iraq.
That is true. There's an association of less severe disease and less spread where people have been vaccinated with BCG. Bacillus-Calmette-Guerin is a pediatric vaccine to prevent tuberculosis. Now, if you're giving the vaccine that religiously, it tells you that you have a fairly good healthcare system already in place. So causation is not there yet. It is a very intriguing observation. It's actually one that I myself am intrigued by. I follow it, but other than the first few papers on lower incidence and less infection, there haven't been a lot of follow-up publications.
We have a question about the question is, what is your overall response to the World Health Organization and CDC? Is this a money issue or a leadership issue? Will they recover from this? So the question is about World Health Organization and CDC. What do you think?
Well, when they, from personal knowledge, when they cut the budget at the CDC from 13 billion to 5 billion roughly, you can imagine the senior leadership, the truly knowledgeable people left. Would be in your position if they cut your budget 2/3. Is have a good day. I get a job somewhere else. So the true thoughtful leadership is gone. Now, can we get them back? I don't know. These other people are going to have to grow into it. With the World Health Organization, they already, for their complex job, have a relatively small budget. We should invest in it. The idea that these infectious diseases don't recognize borders very well, we need to know what's going on. There needs to be a single place that collects the data and sounds the warning. Now, admittedly, the WHO was slow on the uptake on this. I think that they heard the word coronavirus and said, maybe, maybe not. Let's see what happens. I would think at the CDC, there was no one really senior enough, experienced with pandemics to say, wait a minute, you don't have 200,000 cases in 3 weeks without something very dangerous going on.
This is probably one of our own students. The question is, when do you think we should open our campus, USF campus, to go back to the classroom again?
We draw students from all over the world and all over the United States. I think we need to be able to guarantee them a safe campus. And if you think, if your child is going somewhere to a university, you think, what are they doing? So I would very strongly favor everyone wearing masks and the availability of free and frequent testing.
Dr. Sinnott, I just read today, this afternoon, a couple of hours before the program began, about the success of Germany in addressing the corona threat. Do you know what they have done right? What are the things that they have done that we haven't done? Because apparently they're almost sure that they're going to be able to go back to the normal times within a few months, if not within a year. What did they do right? Do you know why they have been so successful as opposed to the situation here in the US?
I haven't analyzed it, but Germany has an excellent healthcare system. It's much more socialist than the United States. They track patients well. And if you look at coronaviruses, they spread from family clusters. So what you have to do is test. When you find someone positive, go to their house and quarantine them. And the Germans seem to be really good at that. So if they're not in contact with other people, the virus doesn't spread. They did it for about 5 weeks, and Chancellor Merkel, her observation was, I think she said, we pay now or pay later. Let's get it out of the way. Now, the risk they threat, the threat they're risking is that their neighbors have not controlled it. And it is the European Union.
I have a question from a mother who's asking, when should elementary schools open, in the fall or later? And is there a difference between opening up an elementary school versus a university?
Yes. For an elementary school, I would suggest that there's a whole lot of exchange of biologic fluids going on in terms of young kids playing, biting, etc. Up until, this is a very rapidly changing area. We've known about the virus 120 days. We don't know if it's mutated, but it now seems to be involving more children. I don't think we can make a decision about this fall till we see to what extent the children are getting involved. Initially in China, in all of Wuhan, there were only 9 pediatric deaths. And I think most of them had congenital heart or lung disease. But the story was different in Italy, and it's also different in the United States. We need to understand this better before we make a decision. You know, when you get the kids together, strep throats start, everything starts, and then you're trying to tease out coronavirus from that. That's very difficult.
We have another question from somebody who says that I am anxious to go to see my dentist. Is it going to be safe to visit the dentist's office now?
Yes. Dentists, of all people, of all medical specialties, other than maybe ear, nose, and throat, are especially careful of airborne pathogens. Notice the way they gown up just when they're going to put a filling in. I would feel perfectly safe going to the dentist. As a matter of fact, on a larger scale, many people are deferring health care for chronic conditions, diabetes, heart disease, multiple sclerosis, hypertension. They should not do that. The doctor's office will protect them because by protecting them, they protect themselves.
There is a question about, the question is why the southern part of the globe, like Africa and South America, were not hit by this virus, and what are the leading nations in exploring treatment?
Let me go backwards. The leading nations in exploring treatment are obviously China, the US, Great Britain, Germany, and France, and Spain, and Korea. These have superb scientific enterprises, and they are putting a full court press on this. The second question was, why is it less prevalent in Africa? I would tell you, having been many times to Africa, that disease reporting and public health resources are very scarce. For instance, in Sierra Leone, entire country, there's less than 15 doctors. It's in Africa, it's killing people. We just don't know how many. And the same thing is happening in South America. It's more obvious, it's gotten there a little later. And South America does not have travel the way Europe, America, and China do. There's much less air travel in South America than there is, say, in China or the United States or Europe.
We have another question. Believe me, we have so many questions, I don't know which one to choose. But this is a good one. What are your thoughts on herd immunity, allowing people to be exposed and develop natural immunity? If this is something that we should consider, how many people do you think are going to die before we reach that critical level?
Well, on a population basis, about 2.5%, 2.25% of people that get the disease die. It's a horrible death where you drown in your own secretions. We also do not know the long-term effects of this virus. Its very close cousin, SARS-CoV-1, looked like everybody did okay that survived. When I returned at 5 years, 1 out of 6 people that had survived had pulmonary fibrosis. 1 out of 8 had aseptic necrosis of the hip. 3% had cognitive difficulties. So we're not sure what the long-term effects of this are. As far as herd immunity goes, to even have a chance at using it, 70% of the population would have to be infected, and the rate of death would just be intolerable. The society wouldn't stand for it.
I have a question from somebody who has identified herself, and she says, I teach global politics at Carroll Day School in Tampa, and some of my students may be attending this program. We thank you so much for this opportunity. Now the question, the 2019 Worldwide Threat Assessment delivered by the Director of National Intelligence contains guidance on page 21 about the likely pandemic. The 2020 report has not been rolled out yet. Do you think that there is a purposeful resistance to its release because it might even contain more specific warning? Very sorry for this political question. Just interested in your perspective and insight. Thank you very much.
That's a great question. I love the specificity. When you look at these documents, the recurring theme is the number 1 threat is influenza, the number 2 threat is coronavirus. They can come out with a 2020 report, but that they can't change that. Right now, we still run the risk of a terrible influenza pandemic. These events are utterly random. I feel they're increasing in risk, however, because of our intrusion into wildlife areas with overpopulation, global warming, which changes the relationship between the environment and ourselves, massive global transportation. Finally, our supplies of food are transnational as well. Strawberries come from Guatemala, etc. It seems that in some ways, progress itself is responsible for these pandemics.
Another good question here is, it appears from Anna, it appears that COVID-19 mortality rate is lower in Florida relative to other states. And I believe Hillsborough County has one of the lowest mortality rates in our state. To what do you attribute this to? Or is that a fallacy?
It is correct. I feel there are 2 factors at work. One, Tampa is fortunate in having superb doctors and superb hospitals. you know, when you have a medical school in a city, all the doctors compete. So each doctor works to compete with the other one and keep up with the latest knowledge. The second issue is there seem to be 2 and probably 3 strains. The strain in New York City came from Milan, Italy, we believe. That has mutated. It produces roughly 270 times as many viruses, it's called strain B, as strain C, which is the original Chinese strain. The original Chinese strain had a lower mortality, about 2%. Milan was 7%. It swept through Milan incredibly rapidly. So I tend to think, I have no proof, but we are working on it as we speak. I think Tampa was lucky, very lucky, in that we were dealing with strain C, number 1, and number 2, the responsiveness to the hospitals. And I have to especially call out Tampa General and the Haley VA as being very responsive to the early warning signs of a pandemic. Usually, the usual phases of an epidemic are you bring it to people's attention, they tell you you're alarmist and ignore you. Then when it's over, they turn around and ask, why didn't you do more? So you have to praise those facilities for seeing the handwriting on the wall, and some of the other hospitals as well, and getting extra ventilators in. I know the Haley VA hospital brought in 16 or 18 ventilators within weeks in case of a surge of patients. Tampa General likewise, and some of the other hospitals. Many of the hospitals educated their medical staff and their nursing staff about what might be coming. So before it arrived, we had protocols on what to do in the ICU, what to do when someone dies, what to do with a nurse exposure. Many of the facilities almost immediately closed their doors to visitors. We just want to deal with the patients we have, not people incubating it, walking around the halls. So I think that the meeting of a milder strain and a well-prepared city made a difference.
We have a number of questions about China. One question is, what is your opinion about Chinese report on coronavirus cases and death toll? Do they look accurate to you?
I would tell you they are accurate to the Chinese, but their mechanism of reporting is much different than America. In America, when I fill out a death certificate, I write the cause of death is heart stopped. Then I have to fill in a second line, caused by, and then I would write clogging of the arteries. Then it says caused by, and I would write diabetes mellitus, okay? Or maybe COVID-19. But in China, there's only one space for the cause of death. So if they have a heart attack, they write heart attack. It's a different medical system. I talk to these doctors almost nightly. We train a number at Tampa General, and I'm always encouraging them to change the mechanism of reporting death. And I think they will. I'm obviously not the only person telling them that.
We have a question from Kelly. She says, thank you very much for your presentation and for the program and the opportunity to present questions. The mask resistance may derive from early advice that they were not necessary. What do you think? Why do you think they were not advised in earlier stages? And what happened to change that?
I think there were, just John Sinnott's opinion, junior people at the CDC totally in shock over a pandemic appearing on their watch, and the United States, because of this just-in-time purchasing, having no supplies of face masks, etc., and they made a decision to protect healthcare workers first. Now, probably at that same time, some of these industries should have been nationalized under one of the Government Powers Act and made to produce a couple million masks a day. Masks, as I said, not only protect you, they protect other people. I think it's, in many Asian countries, it's disrespectful to travel without a mask. People think you'll infect them with something. And now I know why they think that, because I never go outside without a mask. So I think that as the mask became available, their reasoning was everybody should have a mask.
Timothy is asking, would taking vitamin D help African American people? I guess he's asking that question because the mortality rate among the African Americans is higher than the rest of the society. So does vitamin D help them also?
Absolutely. If you have to look at a population with low vitamin D levels, it is the African American community. The dark skin blocks the sun from converting the vitamin D to its active form. Additionally, these communities often don't have access to the best medical care, so they have comorbidities, a higher rate of obesity, a higher rate of diabetes mellitus, a higher rate of cigarette smoking. And these social determinants of health are your social determinants of getting COVID as well.
Another question is about the infection rate, reinfection rate. Are we aware of the reinfection rate? For how long the antibodies last after you recover?
Well, that is the million-dollar question. No one knows. I was called by a physician I know in Japan who had treated another doctor. The doctor went home better. 2 weeks later, was playing basketball and became symptomatic again, returned to the hospital, and had the disease again. Now, is that a reinfection or a relapse? No one really knows. It's an unclear area.
Has he survived?
Yes.
Great. Another question. Are we aware of the mutation rate of the virus? There was a study that showed that there are 30 genetic variants since this virus started last year.
There is a mutation rate number. I don't know it, but RNA viruses are genetically unstable and are the most prone to mutate. And as I said earlier, we're dealing with 3 major strains, and each of them have 5 to 10 minor strains. There is a difference in severity of infection with the different strains. Most mutations are negative. and that they decrease the ability to survive. But you know that 1 out of 1,000,000 are positive, and then that's will begin predominating.
We have a question from one of our PhD students from Afghanistan, Mr. Mourid Parto. The question is, does the environment has any particular effect with this infection? For instance, the number of casualties as well as the age gap between them are different from region to region.
The age gap, we're not sure about. And this idea that there's 3 types of viruses is only 2 or 3 days old. This just came out, and people are sort of absorbing it, okay? So the virus that hit Italy, the bad strain, killed many more people in the prime of life, whereas the data was so clear in China that if you were under 60, don't worry about it. But all of a sudden in Italy, the game's changed totally. Here in Tampa, one of my doctor's daughters, young, healthy, spent 28 days on a ventilator before she came on.
Wow.
So with the Chinese strain, age, hypertension, diabetes. With the Italian strain, we don't know enough yet. That's sort of where we stand now. Now, the effect of climate is a little more complicated. As winter comes around, we all go in heated buildings. The natural mucus dries out in our airways, and that mucus is part of the innate immune system. All mammals have it, and it's very effective at preventing infection. It's not antibody dependent at all. It has lysozyme, there's all sorts of chemicals in it that kill germs. When that dries out, it becomes ineffective. So that's why during winter, you see an upsurge in respiratory illnesses, whether it be respiratory syncytial virus, influenza, etc. As far as the general climate, with the thought that hotter countries aren't suffering, I think a simple call to Laos would tell you that they're having real problems right now, and so is India.
I have a question from one of your students. Are people without the symptoms as contagious as people with the symptoms? And do we know when viral shedding is at its peak?
Yes, viral shedding peaks 2 days before symptoms begin and continues for 2 days after. So that 4 days is the peak. By day 8, after you're sick, you cannot recover SARS-CoV-2. To be careful though, I like to use 10 days, which is the outer limit for SARS-CoV-1, just in case one of the viruses didn't read the textbook. So the peak period of contagion is right before the onset of illness and for the first day or two. The asymptomatic carriers, we don't know much about. We know that they exist. We've identified several in Tampa, and they seem to clear the virus after 12 to 18 days. But this is just on the basis of a dozen patients I've seen. I've not seen anything in the scientific literature about it. There hasn't been enough testing to draw a conclusion.
We have a number of questions about shopping. and this is a pretty good one. What is your thought about using latex gloves, for example, while grocery shopping? Is there any added benefit in using them while shopping?
I think there is. Latex gloves remind you not to touch your face, and they certainly protect you from people that have been coughing on the canned goods, etc. Recall this virus can live on canned goods 3, maybe 4 days. I think gloves are a great idea. What I do is I carry and people sort of laugh, I make a Windex bottle. I empty out most of the Windex and fill the rest with alcohol. And that's a very potent combination for killing the virus. The Windex is an excellent surfactant, and the alcohol destroys the viral fats. I find that bottle more useful. If you have gloves, either put them out in the sun or wash them. Don't be handling them because they would be covered with virus.
Somebody is asking about the Swedish model and herd immunity again. There have been at least 3 questions. So they want to know what pros and cons are there about herd immunity? And is that something that we should even consider using in this country?
Well, there are 10 million people in Sweden. There's 23 million people in Florida. Sweden is a socialist country. Everyone obeys the laws, and it's one of the most highly educated countries on the planet. So when the government says stay indoors or limit your contacts, they do that. Now, whether that's, in a genetically homogeneous country, they're taking a big chance. I don't think it's a very good idea. The main reason is there's no basis at all to think you're immune after you've been infected. So they're basically betting with people's lives, but they're limiting it by encouraging masks and social isolation.
We have a question from Sylvia Fernandez. If we all need to wear face masks for the next year or so, does the type of mask make a difference? Any recommendations? Thank you.
The type of mask does make a difference. First, a surgical mask, a regular doctor's mask, is made to protect other people. Recall, if you're doing surgery, patients don't like it if you drool into a wound or cough into an open lung or something. So they're very good at stopping you from spreading it. They're not as good at stopping you from catching it. They're about 20%, maybe a little more, but 20% is a lot better than nothing. The ultimate in protection is an N95 medical mask, which actually uses an electrostatic piece of material to electrically bind the pathogens. They're not comfortable to wear. Believe me, I wear one all day and my face really hurts at the end of the day. And sometimes I have to take a break just to get out of the mask. An N95 mask would offer the optimum protection. This is what an N95 mask would look like here. It would be prominently labeled. It would say N95, and it would say medical, because many
And how long can you use them, Dr. Sinnott? How many times can you use them?
I've had this one about 5 days. My thinking is that I find one that's comfortable, but I also don't want to use up valuable supplies that are needed by other people. I disinfect it each night with a little bit of alcohol and an ultraviolet lamp. Again, they're in scarce supply.
There are many other questions, Dr. Sinnott, and we are almost at the end of this program. Honestly, there are at least, from what I see on my cell phone, at least 80, 90 other questions. And unfortunately, I know you had a busy day and you're a busy doctor, and so you have to leave. But I have good news for our viewers and listeners. We have recorded this program, and we're going to put it on our site at the CSDS USF World. Please check it out. And I am pretty sure this program has been so successful, Dr. John Sinnott, and I say that based on the number of questions I have seen, is that I'm going to put you on the spot and ask you, would you accept my invitation to come back sometimes within the next month or two?
I'd be honored. I think as doctor actually means teacher. And the more I can inform people how dangerous this is, if I can just stop one person from getting it, I will have done a good job.
Well, I think you probably have done a great job this evening. Your presentation was informative, it was scientific, and it seems to me we live in an age where science, the role of science has diminished, and I think people like you can save all of us. So on behalf of our center, on behalf of USF World, and on behalf of Dr. Krusen, I want to express my deepest appreciation to you for what you did today and for what you have done for our community and for our university. With this, I say good night to you and to our good viewers. Until our next program, good night.
Thank you, and thank you to the audience for listening. I was deeply honored.
Are we off now?